Hey everyone, welcome to the Nursing Insights podcast. My name is Stephanie and I'm a registered nurse practicing in the state of New Jersey. Getting right to it, the state of healthcare right now is tough, to say the least. Let's just say that the nursing shortage does not spark joy. We can sit in that and stew in it for a while, but we can't live in it forever. Things are changing. So join me as your host as I partner with the New Jersey Collaborating Center for Nursing to hear from nurses across the state about their experiences, trials, and triumphs in the nursing profession. Today we have Francesca with us. Francesca is a nurse at Englewood Health. Francesca, welcome to the podcast. Can you tell us a little bit about yourself and how you got into nursing?
Thanks, Stephanie. Yeah, my name is Francesca, obviously. I'm a nurse at Englewood Health. I work on the cardiac step-down telemetry unit of our hospital, and I went to Towson University in Maryland. I graduated in May of 2020, and I took a year off, actually, before I started even working in August of 2021.
So thank you so much for giving us a little bit of that background. So I'm sure I'm going to end up asking you a bit about your experience because I'm sure nursing practice in Maryland, you learned a set of things. And while nursing has its scope of practice that goes from state to state, I'm sure there was still a bit of an adjustment period because just going from patient population to patient population or hospital to hospital, you still meet these cultural differences. We'll get into that in a little bit.
Yeah.
So could you tell us a little bit about what kind of nursing unit you work on and what that looks like?
I work on a cardiac step-down and telemetry unit. So my unit specializes half of our unit works with cardiac step-down patients. They have open heart surgeries, which is cabbages, we call them. It's bypass. We have aortic valve replacements. We see a lot of chest tubes and people with just heart conditions. And the other half is any kind of patient who needs close heart monitoring. So it doesn't necessarily have to be just a heart problem. They could have kidney problems or GI problems and just need a close monitoring of their heart also. We have a monitor tech on our unit who has access to see every patient on our floor and their heart rate and their heart rhythm, and we keep track of everybody, which is really very helpful.
That's wonderful. So depending on which side of the unit, you work on both sides of the unit?
Yes.
So depending on which side of the unit that you work on, do you have a different ratio of patients, a different number that you're expected to care for, like on your shift?
So the step-down patients are a little more high acuity. They are a 4-to-1, so our max is 4. And then if you're on the telemetry side, you're allowed to have up to 6 patients.
So it does make a difference. And would they ever kind of cover both, or you're kind of on one side or the other for the shift?
In one shift, you're always set to just one side. They don't really mix. If you have a low amount of step-down patients, you can sometimes, like I'll have 2 step-down patients and then 1 or 2 tele patients if the unit needs it.
But then that would never happen in a case that would be dangerous or in a way that would throw the ratios off. So that's totally understandable. And it's interesting too, because you're saying you could have anybody from heart surgery to a patient who is normal in their everyday existence. They just found out that they have an irregular heart rhythm that could cause them to go to a hospital. So you have a very wide range of patients that you might see. Could you tell us just a quick day in the life of what it would be like to be a nurse on each side?
So on the step down side, we get our assignment and get report from our nurses. Bedside is best. Do it with the patient so you can check. We have a lot of patients who have chest tubes. They have infusions going and external pacemakers. So we have to make sure we do it with the other nurse so we can check all of that and make sure everything the day shift nurse is saying matches with what I'm seeing on my patient. After that's all good, you do your assessment, you check the computer, you like to go through the chart and make sure you have everything set for the night. No questioning thing. Like you can question things, but you want to make sure that you don't see anything questionable. Like maybe this shouldn't be happening for my patient. We'll give meds and settle our patient. I work night shift, which makes it a little bit more different. So after I give my nighttime meds about between 9 and 11, on a good night, everything goes as it should. I can settle my patients into bed by 11:30. And then if they sleep, the high acuity of my step-down patients, we need to check their vitals a little more often than the telemetry side. So every 2 hours, I have to go in and check the blood pressure and the heart rate and the oxygen on my patients. Whereas on the tele side, I'll get to that later, we only need to do every 4. Until about 4 o'clock in the morning, we have to clean all of the wounds on my patient. So they get open heart surgery. So we have to clean the dressing on their sternum. They have the chest tube sites that we have to clean every single day. We don't want any infections. And then We get them out of bed. This is a tough one because we have to do it day one. Like we get the patient out of bed into the chair, and a lot of them are still in a lot of pain. So they need a lot of encouragement. We give more meds and get ready to give day shift report. We take labs in the morning, so we have to adjust any electrolyte imbalances that we see from the night before, a lot of pain management, and just settling them in.
It sounds like you're doing 12-hour shifts, right?
Yeah, I do.
Yeah, there's quite a lot to be done in 12 hours. And then if you want, you could just go over what are some of the major differences between the step down side and the tele side.
So telemetry works kind of similar. You get in, you settle, you see your patient, get report, give your medications, and then they only need every 4 hours vital checks. And there's actually a stipulation at nights that if your patient is sleeping between 11 p.m. and 4 a.m. and they're stable, they're not any big problems, especially because we have the heart monitors that we can see them all night long. We don't need the midnight blood pressure because we don't want to bother, like if they're mostly stable, we don't want to bother them. It's almost more irritating for them than sleep is important.
Sleep is important, and it's hard to get in a hospital where there's beeping every 15 minutes and there's plenty of rounding being done. Absolutely.
And then in the morning, the telemetry side, they don't have the strict getting their patients out of bed into the chair. Some of the patients do like to because breakfast comes, obviously, and it's a little easier to have breakfast in the chair, but that's not a must do, whereas the other side it is.
Wonderful. I mean, yes, because you're going back and forth. Both sets of nurses can exchange. So it could be, you could be placed on one side for one part of the, your week, and then on another shift during the week, you might end up on the other side of the unit.
Yeah, the nurses on our floor are cross-trained. We learn from the start of residency, this is a new thing for us. We teach our nurses right away, both sides. They used to only start them on the telemetry side, and then I think they needed like a year maybe before they were allowed to start learning step down.
I see. So you were part of a residency as well. That's something that we've been bringing up a lot in our conversations. Could you tell us a little bit about how your residency prepared you for step down and for tele?
Made it really easy, not easy, but like better to learn everything I needed to about my tele and step down patients. I'll say tele a lot. It's just telemetry. We shorten it. So residency helped me with my starting in tele and step down because you are assigned to one nurse in the beginning, your preceptor, and that preceptor basically gets her schedule and her patients like a normal day for her. And then you follow her and you learn from her and you get your own patient, everyone like from the start. It was nice to see the nurse that you work with go back and forth. So you see how she does her days on telemetry and then on step down. But yeah, and then we also did things in residency we have a simulation lab, kind of like in a lot of nursing schools. I know in mine, we had a simulation lab. It makes it easier to learn. We do mock code where they give you scenarios and you have to see what's going on with your patient. And they're on the telemetry monitor, which is good because we have that. You get to assess and see what's going on. And there's no outside experienced nurses with you. Well, they're the teachers, of course, but we get to kind of make all of our decisions ourselves. And it's a big confidence boost.
It's wonderful practicing your skills and also being able to know that at the end of the day, this is a practice round. When you get out there, you've done it before. And did you have like a group with your residency? Was there a big cohort with you, or was it a couple of folks?
I think I had a really big cohort, actually. One of the bigger ones that I've seen in Englewood. Very nice to come in and have 10 other people who are going through the same thing as you, and you're starting off in the same boat. Everyone's a new grad, so they're all learning all the skills the same as I am, and so we were all just in it together. Yeah, we had a big one, and we're all really close. We still are all super close, which is so nice.
I love that. That's an experience I missed out on because in my hospital, when I started out nursing, I had one other new nurse with me at the same time, and we stayed in touch. But I think the supportive atmosphere of having a lot of nurses who are in this together, starting from your practice, as it begins, is such a cool experience. And you also mentioned your preceptor. Was she your mentor for the entire process of the residency, or did you have different mentors?
My residency was a little different than someone who's, say, on day shift. Because I was on night shift, we start in the daytime. We do, I think, a month or a month and a half on day shift. And we work with a preceptor on day shift, and we learn with them and everything that they do, which is nice too, because now I still know like everything day shift does. So if they have a busy day and I get some stuff to do at night that I wouldn't usually, I'd be like, okay, like I know that daytime can be busy and they're not just doing this on purpose. Then we move to nights, and at night I get a whole new preceptor, and I learn a whole set of new things from her and a whole new workflow from her. And so yeah, we try try to keep the same preceptor throughout your residency, which is nice because then you form a really good connection, and it makes it a little easier if you're having problems to go to them because you know them really well at that point. But I had good relationships with my day shift preceptor and my night shift preceptor. There's instances sometimes when you have someone that you don't click with, per se, that's a good word. You don't have the same kind of teaching and learning methods, I guess, which makes it a little difficult. I had that for 1 or 2 days if my preceptor wasn't there and I had to be with someone who I'm not usually with. So it's a little intimidating, and then you get a little nervous and the other one doesn't know you very well, so they have a hard time trusting you. But I loved my night shift preceptor, especially. She was like, I called her my work mom. She was the best. I still talk. She actually switched departments, which made me devastated. I still talk to her. I see her all the time. She's the best. And it made it really, she was very supportive. She gave me she was good at balancing, like, you should be doing this way, or like, maybe try this way, it's better. And then saying, you are doing such a good job. Like, I'm so proud of you. You're going to do great when you're on your own. You're so close to being ready. And it made it really easy to be on my own.
I actually got a chance. I have spoken with a couple of nursing students prior to coming onto the podcast to ask them, what are the things that you want to hear about? What are the things that, you're looking forward to or even anticipating, when coming into the nursing profession? And something that some of the nursing students had talked about was this culture of eating your young and how they heard about it in nursing school. And I think, different people have different experiences like that. And some people have very positive experiences, encountering senior nurses or more experienced nurses. And then there's always senior nurses that reach out and say, hey, like, we're going to help you become the best nurse you can be and mentor you through the process. Do you mind sharing a story maybe? Do you have any stories about your mentor or anything that she did, like, as a specific, like, tangible moment that you guys had in which you learned something?
She actually was not like a senior nurse. She's only 5 years into her nursing. So
hey, she's an experienced nurse. That's okay.
What I remember from her being my preceptor was just all the time, like, at the end of every shift, we would walk out together and she'd just be like, oh, how did you feel last night? Like, I think you did this really well. And like, you're starting to get your confidence. And
it really is wonderful to have that affirmation, because the first year of nursing, I feel like especially every nurse is scared. It's a profession in which day one, you are taking care of somebody. Somebody is depending on you. You are responsible for somebody's well-being. And that's something that no other profession can really claim the same way nurses can, which is an amazing thing about our profession. And actually, one of the things you had said a couple of minutes ago that I was interested in hearing about. So I also worked tele and I had some rotations in the ICU. And I remember the first time I saw an external pacemaker and just like the experience of being like, wow, I didn't even realize this was possible. Do you have any moments from your practice so far that really were interesting to you or really opened your eyes to like, this is nursing, or this is something that I'm excited about doing in my profession?
This doesn't have to do super like with tele or step down even, but I have a lot of patients who are like in intense, crazy pain sometimes, especially chest tubes where they get placed. Sometimes the nerves can have like spasms, which causes them crazy pain. And they always complain, like, I feel like I can't breathe and I'm in 10 out of 10 pain. And just getting that under control, and then the relief that they feel and the appreciativeness that they have for you after the fact, it's just a really good feeling. And it's like, oh, I love my job. I love the fact that I helped this person who was in crazy pain and felt like they couldn't breathe, who literally said to me, I think I'm about to die. Like, and then an hour and a half later, they looked at me and they were like, thank you so much. Like, I can't thank you enough.
Yeah, you can walk out of the room and say, I helped somebody. Like, I made a difference.
Yeah.
I today did something good for somebody in this world. It's like a super great experience. And actually, kind of on that note, would you mind sharing with us a little bit about how you chose nursing as a profession, or how you got into nursing school, or your process for deciding that you wanted to be a nurse?
Growing up, I was always very into like helping people, which sounds very basic answer, but in the sense that I did gymnastics, and every time someone would fall or get hurt, I was always the one rushing with the ice or wrapping ankles, helping people when they were cut. I actually remember, this is totally different, but another summer, my grandma was in a very bad car accident, and I spent, like, she was in rehab. She had a broken arm, a broken ankle. She was overweight, so
awful.
She had some mobility issues. And I spent almost every day. It was in high school. I think I was 14. I spent every day that summer almost going to rehab and like sitting with her and helping her and being like, you're doing great. Like, keep pushing through, like just trying to help her with her process. And I liked seeing seeing all the people in the rehab coming in and helping her with her PT and her meds and all that stuff. That was really nice. Even when she got out, I was her little, she had diabetes. I was her sugar checker. I had the glucometer. I was checking sugars back when I was 14.
And that paved a way. That paved a way for you to come into the hospital.
I was her little nurse, and then now she inspired me to go to nursing school and be what I am today.
What a beautiful story. So how is it that you even ended up in step down in cardiac, specifically within the nursing field?
Funny enough, I hated my cardiac section of nursing school. I could not get a handle on heart rhythms or like potassium flowing and all the problems that came with cardiac. And when I was looking for a job, I found Englewood and just kind of put my resume in, and they called me and they said, which unit are you looking for? I work on 7 Dean. That's the name of our unit. They had 6 Dean and 4 Dean. One is in oncology neuro, and then cardiac pulmonary. And my unit is the cardiac step down telemetry. I think a little part of me just likes the number 7, but another part of me also thought cardiac was a good place to start, even though I was a little nervous about the fact that I didn't particularly like it. I'm more of a hands-on learner, and I know that being in school, I struggled with some concentration sometimes, like lectures and stuff. So I was hoping that being in my job and a hands-on, I would learn a lot better, which I have. I thought it was a good place to start out. Even if I didn't end up loving being on this floor, like I do, I would have a good foundation and be able to kind of move to a different unit relatively easy.
Yeah. And I would be absolutely confounded if you weren't correct, because like you're saying, it's true. Cardiac, it affects literally everything. Like you have an understanding of where everything goes. And I think it's also wonderful that you ended up coming back in and slaying your dragon, something that was once challenging. Now you're, doing without sweat. So I'm sure you just brought a lot of hope to maybe some of our nursing student listeners who may be kind of going through the slog of memorizing ratios and memorizing things.
I was the worst.
I am certain that for you and for all of the students who are out there, there is a lot to learn, but then a lot of growth that comes with it, and then a lot of triumph that comes with it too. I think you shared a little bit about this, but maybe if you have any others, any moments in which you had an experience in which you said, like, I am triumphant, like this was me at the top of my nursing game, I did it.
When I was just off of orientation, I had a night where I was the most senior nurse. And as the most senior nurse, we have a good amount of orientees coming in and new nurses, and they're very trusting on our floor, which is nice. We have the most senior nurse on the unit usually be the one in charge. Unless there's several who have been there for years at a time, then they let it rotate. It doesn't really make a difference. But in the scenario that I was in, where I was 8 months in, they put me in charge, which was terrifying as a new nurse. But also it made me feel really good because they had a lot of faith in me. They were trusting. They knew who I was, and they knew that I had the capability to be the one in charge. So I made it through the night. We had a couple of hiccups, some patients with either rowdy family members or people who didn't want to leave when they should. And I made it through the night. I used my own judgment, and I dealt with people when I needed to. I called a supervisor when it was appropriate. And at the end of the day, I made it through, and it was a good feeling. I was like, wow, okay, like I can be in charge. I liked this job. Maybe I'll try to do a little more from there.
Yes, the moment where you said, I can do it. You can do it. So congratulations. And that's another part about being a nurse, is that there are some jobs, like maybe some, nothing to say against being in an office, but you might be able to choose who you interact with day in and day out, or you might know the same 20 people are going to show up to your office building and come in and out. In nursing, every day is different. The people that you meet are different. You might have the same patient or the same families a couple of days in a row, but that's not necessarily going to be the case the next week or the week after. So the amount of flux, the amount of flexibility that comes with having to adapt in the nursing field, it's tremendous. It's a lot. So congratulations to you for getting through your first shift as charge nurse.
Thank you.
So Francesca, you started working in August of 2021, and the pandemic was still around, maybe not to the same heights as it was around the time you were graduating, but it was present. Could you tell us a little bit about your experience of being a frontline healthcare worker, of being a nurse during the pandemic?
It was intimidating, for sure. I also felt the strain of some of the other nurses on the unit who had been here with the more dire times, like when they were really in the thick of it. My preceptor told me some crazy stories, that's for sure. But for me, it was kind of just different. I felt more the need for the empathy with the patients because we didn't have family privileges. Like I think maybe one family member was allowed all day long, and but they had like maybe a 4-hour window or something like that, which I personally understood because I had a family member in the hospital during COVID, actually my grandma, who in July, she was in the hospital in Italy in July, and no one was allowed in the hospital. Italy didn't let people in the hospitals at all. So she was alone, which I hated, and she ended up dying alone.
I'm so sorry to hear that.
Okay, thank you. So going into the hospital straight after that, it was literally 2 weeks later that I started. It kind of gave me more of a sense of empathy, really, to make sure that everybody felt like loved and like they had someone sitting there with them, because I know that's what I would have wanted for my grandma, to be with someone, have nurses who felt like they cared enough to sit with you. If I didn't have a lot going on, maybe I'll spend an extra 10 minutes even just sitting there hanging out, talking.
I mean, I'm so sorry for the loss of your grandmother. I affirm you in the act of bringing the compassion that you needed in that moment to now your patients, be somebody who is able to be the person that you wish you had for your grandma at that time, because that takes a lot of heart to be able to be present for others in that way, considering the experiences that so many people have had. I'm sure you've made a difference for a lot of people by being present for them.
Thanks.
So I see, Francesca, that you have began leading or co-leading the unit-based teams for your unit. Could you explain a little bit about what that means to us?
So our unit-based teams, we have 2 people that lead it on the unit. It's kind of just a sense of, we get a meeting once a month and we go through any challenges. People have the opportunity to speak up and say, this is going on, and I think this could be used better in this way. And we have little projects that we work on. Last year, we worked on increasing workflow between our cardiac cath lab, which we deal with a lot, and then with our unit. We see a lot of cardiac cath lab patients on our floor. So making a smoother transition from one to the other was our big project. However, I do not work with the unit-based team. Well, everybody works with the unit-based teams, but I no longer co-lead the unit-based teams. I now am care manager on the unit. So I pass the torch to one of my fellow night shift nurses.
Okay, so could you tell us a bit about care management?
Sure. It's a bit new to me. I started in April, and it's comes with all the same duties as charge nurse. So I go in every night. I'm in charge of the unit. I have to check all the code equipment. So the defibrillator, make sure the code cart is locked and all the medications are in. I have to make sure the assignment is correct, and the PCAs have their assignment. Our nurse technicians basically make sure everything is set and all the admissions are assigned. And then just any problems that come onto the unit, people come and ask me for help, and I'm able to do that. And then on other days, we get to, as care manager, revise protocols on the unit that we think could use adjusting. So we get to revise protocols. We get to make sure everything is up to date, and that if there's anything that needs changing, we can bring those to the manager and try to work with them. We are on a council, and we meet once a month with someone from each department, which is nice. And again, we just address anything that can be fixed or changed within the hospital and our unit.
So for something like changing the protocol, is that something that you and your fellow nurses on the unit might notice, one day when you're administering something or going through the list of protocols, when you reference the protocols, and then you'd bring it up to your team and bring it up to the monthly committee? How would that play out?
Yes and no. A nurse can come to me or manager with a concern about a protocol and be like, you know what, I've read up on this and I see that there's kind of like a new way that they've been doing this, a change that we can possibly implement. And then we take it from there and do some research. We need all the sites and to make sure this is in the best interest of our patients. And we write up a whole thing and then give it to the medical surgical council, where everybody gets to go over it, and they can all also give feedback and say, like, I think this is a good idea. No, I don't like the way this sounds, and kind of just adjust it. They tweak it a couple of times actually before the final product is sent out to steering. But yeah, so it goes by so many people before it's approved and able to be implemented into the hospital. But otherwise, it's just every protocol has to be reviewed every so often. So each unit gets assigned certain protocols that kind of we deal with the most. And then we get to review it and make sure it's up to date and get new literature put on it. And then we go from there.
And then once that is finally changed, is that something that you as the representative would come back to the unit and say, hey, we're changing this protocol, and you do teaching with your fellow nurses?
Yeah, we if there's teaching needed, we do teaching. If not, it's sent out in an email to everybody with an attachment to the link so that they can see, like, it comes out, it says protocol has changed in this month, and then they send out the email. And if it's an education thing, the educators will come in and do little huddles in the morning, or they come in and they have papers and everybody has to sign it to say that they got the education needed for this new protocol.
Great. Thank you so much for explaining that. I feel like those are the little things that you learn while you're in the hospital, but maybe prior to that, if you're out in nursing school or if you're looking to get a hospital job, those are those little things that you wouldn't learn. So it's cool to be able to share those experiences and also to show how it is that our hospitals and how our practices stay up to date, because it's a conscious effort to keep learning. It's a conscious effort to make sure that we are on the cutting edge of whatever research is showing us with evidence-based practice. So very, very cool. Are there any other roles that you've been interested in or that you've picked up? Have you done any mentoring, for example?
Oh, yeah. I know that my preceptor had such a big impact on me, and like she was such a big role model to me that I wanted everybody else to have the same experience. I want everybody to feel the way I felt. And I would like to do the most that I can to make sure they feel that way. So as soon as my manager gave me the opportunity, I started precepting people. I think it's really important to make sure everyone feels like they have the proper learning. Like some people like to be told, like, you should be doing it this, and this way. And I was the kind of person who I was like, when you hover over me, I feel a little bit nervous and I'm not going to do the best job that I can do. So if you can stand back and watch me, like keep an eye on the computer and on my job, like on my skills, that's great. But otherwise, and like interrupt me if I'm about to make a mistake, of course. Otherwise, I will come to you with any of the problems that I have. That's how I was personally, but not everybody's like that. So I like to get my orientees and I ask them straight away. I'm like, how do you like to learn? Like what's going to make you feel the most confident in yourself? This way, by the end, they have the confidence that they need to be on the road.
So Francesca, do you have any advice for maybe student nurses or new nurses that are getting precepted, but maybe don't have the right match or maybe aren't aligning with the way that their preceptor is trying to teach them?
Yeah. So with orientees, I say always feel free to speak up and ask questions. You can never ask the wrong question. If you don't feel super compatible with the preceptor that you have, it could be a good idea to maybe reach out to your educator. Say, my preceptor, while she's super smart and does everything really well, I don't feel that we're compatible and I don't feel I'm learning as well as I could be. And if anything, maybe they'll talk to the preceptor and say, like, how are you trying to orient and what can we change? Like, how can you help her learn better, or him?
Yes. And I think that kind of clear communication is super important, especially as we're talking about changing that culture of nursing to something that's very open and welcoming versus the historical impression that's there of being a place where newer nurses struggle.
Yeah.
Do you feel like there's anything that either you've seen or that you want to do for other nurses that would help change that culture?
As the experienced nurse now, I guess, I think it's just important to show the new nurses, like, some days I will be a ball of anxiety. There are stressful days. Don't get me wrong. I love my job, but sometimes I want to rip my hair out, and let the new nurses know that, like, yes, that happens and it's just a part of the job. Like, but there are also the days that I will leave here and be like, I did an amazing job and I am so happy with how last night went and I helped this one and I saved this life, and it's a good feeling. So they know that there's a nice balance between them. And then also just keep asking them questions. If you see them struggling, reach out, say, what's going on? Can I help you? How do you feel about how it's going? Even if I'm not your preceptor, you can do it with anyone. Ask all the orientees you want. Make sure everybody feels welcome.
On the other hand, I guess then for continuing into advice for orientees, do you have any advice for new nurses or for nurse residents that maybe are struggling with their confidence or struggling with that first couple of months in which things are very new?
You start off really low or like not knowing anything, and then you get to the point where you're like, I feel confident and I know what I'm doing. After like 6 months, there's a dip where you realize that this is the job you're going to do for a while, and it's overwhelming sometimes, and you're going to feel like you don't know anything anymore. You go from feeling like you know nothing to feeling like you know everything to then feeling again like you know nothing. And that 6-month period is really difficult. I know I thought about quitting like a couple times because I would go home so overwhelmed. And again, I know we've touched on this, but the support of my coworkers, me and my unit, we have a really great bond. And we could talk to each other all the time, any time of the day, and just reach out and be like, I had the worst shift and this and this. And they push you and they're like, you know what? It sucked, but tomorrow's a new day and we'll get through it. And that was really important to me. But then after that period, you start to realize you are making it through every day. Like while they're stressful, you are making it through and you're doing everything right. It gets better. And then you're a nurse. And then you're a nurse.
And then somehow after a year, you're like, I survived. I took care of people, and I'm enjoying my job.
Exactly.
There's a bit of a ramp up sometimes, but then the payoff is incredible. Like knowing that you can help and knowing you have that ability to take care of somebody in their most critical state. That's one of my favorite parts about being a nurse. I remember hearing that when I was a nursing student, being like, you will be with people on their most vulnerable days, on the worst days of their lives, and like you will be the brightest part of the worst day of their life. And we get that experience every day.
We do. Even on the bad days, we do.
Even on the bad days, we get that. It's an awesome place to be. Kind of in relation to those some days being hard and some days being awesome, how do you personally take care of yourself with those stressful days and with those tough days? How do you help yourself bounce back?
I do a couple things actually. As night shift, sometimes I really just need to reset by sleeping, turn it off and turn it back on. I sleep for hours until I feel I have my energy back. And then some days I will spend hours in the kitchen. I like to cook. So cooking is cathartic for me. I like sitting there and learning recipes, listening to music, and then of course eating it after. But yeah, I cook, I sleep, and then I try to make time for everybody. It's which you'll learn, especially not you, but the new nurses, they'll learn it's really difficult to balance seeing all the people that you love and you want to make time for, especially starting out new. I think the first year of my nursing, I barely saw anybody. Just keep reaching out and telling people, I miss you, I want to see you. I'm just a little busy. And then if you have a couple days off, make time to make days off. The nursing schedule is really cool. I have some weeks where I can work 3 days, Sunday, Monday, Tuesday, and then I'm off Wednesday, Thursday, Friday, Saturday, Sunday. So you can take that time and go places, see things, see people, do things that make you happy.
And staying connected to people is a big part of that. And thankfully, our schedule does have that flexibility. With my first job as a nurse, I was in an 8-hour shift and I did 3 to midnight. So that was the time that everybody was out, everybody was having fun, and I would get out and it'd be midnight and everyone was at bed sleeping. And it took a while to find that time to make those pockets of space. But then again, things adjust, things get more comfortable. You leave work feeling less stressed out and you're able to eventually go out and make that time for yourself and recover.
It gets easier
it definitely does
as the time goes on. The first year is tough, but you learn, and now I have a better balance between seeing people and working.
And again, the residency helps that, the mentorship, the coworker support, having a good culture, all of that comes together to make the experience better. And still related to the people around you, if you have advice for maybe a family member or a friend or somebody who loves a nurse, do you have any recommendations for them and how they can be supportive of the nurse that they love?
Kind of just the opposite of what I was saying. Know that your nurse is tired and doing the most that they can to help other people, which I know you want to feel like they're reaching out and giving the most that they have to you, which is kind of tough. But for family and friends, it's hard to know how busy we really are. And they see us and they're like, oh, well, you only work 3 days a week. Yeah, but they're the longest 3 days of the week. Like I need the other time to relax. Or if I work, it's not always 3 in a row. Sometimes I'll work Monday, Wednesday, Friday. That in between days, I'm either like cooking or sleeping and recharging and getting ready for the next days. And then holidays are a struggle sometimes. Families don't like to give up their family, right? They're like, well, why do you have to work? Well, somebody's got to do it. So just having a little grace with that, and as family knowing like, okay, you have to work. I get it. Go make someone's Christmas a little better. Try to act like that. It's a little tough.
At the end of the day, the loved one that you have, your nurse who's out there making a difference for somebody, they will also, the pressure that you take off them by relieving, some of that external pressure will also help them, because at the end of the day, they will have time to spend with you. They will be able to make the time to spend with you, but but that extra
Yeah.
pressure does help when it's off your shoulders. We're starting to wind down with our time. So I was kind of leaning toward those last couple of questions. Is there anything that you personally wish that people knew about nurses or their patients realized about nurses when you come in as a nurse, that you're also a human being too, kind of thing?
Yeah, kind of just that we're human. I know I don't know if this is a bad thing to say, but we make mistakes, not in a life-threatening way, right? But if I am with you, seeing you, and you ask me to refill your water or something, and I say, yes, I'll be right back. Like, let me go get that for you. And then suddenly someone's down the hall and they need something for their patient that's an immediate thing. Like they need help with an IV access. And you know what? The water accidentally just slipped my mind. And I come back and then you yell at me for forgetting your water. I'm so sorry. I didn't mean to at all, but I'm human. The little things like that. And I know that it's hard for the patients in the hospital. They're scared, they're hurt. So sometimes that fear turns into anger. So I try to remember that too. But they got to remember that like we're trying our best. And we're human. Sometimes something slips my memory. I've got a million things going on at once. And hopefully they can try to be just as graceful as we try to.
Yes. And there's so much going on, I think, related to that. There's so much going on behind the scenes in our brains of prioritization that sometimes, as much as we want to get you that water, we just can't in that moment. It doesn't mean we don't want to get it to you. It's just that there's a lot of things happening. So yes, nurses are human and we deserve grace, just as every other human, just as we would ask of any other human.
Right.
So Francesca, you had mentioned your residency. Could you tell us a little bit about what that experience was like and what are some of your favorite parts of it?
Yeah, I think my residency really impacted me in a positive way. Like I said, it gave me immediate friends, immediate support group, and it gave me a reason once a month to meet with everybody from my department, from the other units who are also new, and hear their stories. It makes it nice when you have people from every unit coming in, because I have friends on all the other units now that I can reach out to and be like, hey, I think I have to send you this patient, or if you're sending me a patient, why are you sending me this patient, without it coming across kind of like we don't want this, or like we're just pushing this off on you. You get a little better. You get to hear all their stories, which is nice. And then they have meetings every month that they have guest speakers, so things that wouldn't necessarily only apply to my unit. Like we had the wound care nurse come, which she applies to everybody. Everyone's going to have patients who have wounds, and they taught us all the stages and everything to look for and all the consults that you can put in on your own. They teach you where to find all your protocols and all the little things that maybe slip by with your preceptor.
Just having the access to a whole other group of bright minds, a whole other people, a whole other set of people who are thinking, who are learning, who are challenging and kind of growing alongside you is a really cool thing to have. How is it that you got into the residency? Was that an automatic entry when you joined as a new nurse, or was that something you had to apply for?
Yeah, so when I applied it was just a new grad position. It was a residency position. Anyone who hasn't worked for at least a year, like nurses with no experience under 12 months, I guess, they all get put into the residency program just to ensure, like I said, it just builds confidence, honestly. Maybe some of them feel like they don't need it, but it's super helpful. Even if they have worked a little bit. I know actually one of my coworkers, she started working at a different hospital. I think she put in like 3 months there maybe. And then she came to us and she still did she had to do the whole residency program. But I think she also would say that it was beneficial to her.
All of the opportunity to just learn in an environment that's made for learning is great. So speaking of which, what were some of the speakers that came in and gave you some feedback or gave you some information?
Yeah, we got to see people from just a bunch of different departments. The wound care nurse, we got to meet with the rapid response department head, who explained to us just a little bit about what they do and where to find them, and to let us know as new nurses, because calling a rapid response is scary, that it's okay. It's okay to call a rapid response. If you think that there's a change in your patient, you should not be scared. We got to do simulations with the coordinator down here in the simulation lab, and IT comes to meet you. They say pretty much what they have to say and tell you if you need anything to reach out, security, all the things. And then they really hit a lot of people on residency.
Because the more people in the hospital you feel comfortable with, I know I've had plenty of moments where I had to call security and it was nice to see a familiar face, or to know that this is not a stranger. This is somebody who has let you know, like, it's okay to call me. I'll be there if you need me. Like, those are all building the connection within the community and within the hospital is important as well, because at the end of the day, everybody is a team member, whether they're from a different unit or they're from a different department altogether. everybody's a team member and they're all here. Everyone's here for the patients.
Yeah, that's I found from the moment I started. I mean, this is something my parents taught me that I thought was important, that it takes nothing to say hello to someone. Every time I pass someone, respiratory therapist, the security guards, the phlebotomist, the other nurses, the supervisors, anybody, like I pass them. Even in the cafe, like when I go down and I say, hey, how's your night going? What's going on? Like you pass them and you can't really have a whole conversation, but it doesn't hurt to say hello, hey, how you doing? And it makes them feel more comfortable with you. And then when you need something important, they feel more inclined to be like, you know what, this is a really nice person. Like, let me go help them.
Working on the night shift, are there a lot of other kind of departments that you end up collaborating with?
We collaborate with a lot of people. There's not as many as day shifts, I guess. You get closer with the emergency room for sure. They come to us a lot. And the cath lab, we collaborate with them, but they tend to finish their nights so they come in real hot at 7:00 with all the patients that they want to get out. So we try to form better relationships with them so that they're, like I said, inclined to, give us a break sometimes, like not send up 5 patients at once where we're overwhelmed. Phlebotomy, I know a lot of the phlebotomists because we're not allowed to draw our own blood unless it's from a central line. The x-ray techs, we meet a lot of people, especially because there's a little myth, you can't really use the quiet word, right? Quiet's not a good word to say in the hospital. But when there's not as many people in the hallways, the few people that there are, it makes it easier to get to know them, which is nice. So all the departments come around and we say hello.
And I'm sure you also see respiratory therapists.
Yeah.
You probably also get your different night physicians. Are you also a teaching hospital?
We are a teaching hospital. We have new residents actually just started this year. We got the new PGY1s. So the new nurses need to remember that the physicians, especially at night, we really only have the first year residents, medical residents, who take care of the patients. And sometimes a new resident is a little nervous. They don't always know the right thing completely and they're nervous. So they're like, you know what, maybe we'll just let the day shift do it. Like, so if you, as a new nurse, if you see something that you think doesn't sound exactly right, or you have a patient who you think needs this, this, and this, don't be afraid to reach out and question the resident. And if they push back a little bit, then you can reach, I would say after a good amount of time back and forth with the first year, you can reach out to the second year. They do have the second years around and be like, hey, I think the patient needs this and this. Be like, your first year said this, I still disagree. What do you think?
Yes.
And then just go from there. Don't be afraid.
To not be afraid to advocate while still also giving grace to the other person. Because again, like you were saying, people are new. It is the middle of the night. It's not necessarily fun to be called at 2 a.m., to be giving some medication or to be asked for something. But we all signed up to be here for the patients. And regardless of our fears, regardless of our concerns, we're going to work together to get that for them, whatever it is that they need. So absolutely, everybody deserves a little bit of grace and everybody deserves the confidence, or everybody should have the confidence to speak up and advocate for the patient as they see as necessary. Thanks for listening, everyone. We'll see you next time on the Nursing Insights podcast.
This podcast is brought to you by the New Jersey Collaborating Center for Nursing and the Rutgers School of Communication and Information.